Hey everybody, it's Dr. Eric Balkavage again. We're back for another Thursday thyroid video. And today we're going to talk about patterns of hypothyroid dysfunction. And we'll start today with primary hypothyroidism. But before I get into that, we're going to start with just a quick review of what we've talked about in the past. The more we repeat it, the more you learn it. So every cell in the body has thyroid receptors. So the thyroid hormone is what really runs our metabolism. The more thyroid hormone we get into the cell, and the more it helps the tissues in the cell function, the better, faster our metabolism is. So when cells become low in thyroid hormone, they send signals to the hypothalamus to say, hey, we need more support, we need more thyroid hormone. The hypothalamus releases thyroid-releasing hormone. That thyroid-releasing hormone goes to another gland in the brain called the pituitary gland. The pituitary gland releases a hormone called thyroid-stimulating hormone. Thyroid-stimulating hormone, to make that, we said not only do you need to understand the pathway and measure the pathways and the major thyroid hormone test, but we also have to look at some of our micronutrient status. If somebody has a low thyroid-stimulating hormone on their lab panel, it may be because they have protein deficiencies, magnesium deficiencies, zinc deficiencies, or B12 deficiencies. Once we have appropriate thyroid-stimulating hormone, thyroid-stimulating hormone goes to the thyroid gland to tell the thyroid gland, hey, kick it into gear, let's make some more thyroid hormone. Your thyroid combines tyrosine, iodine, B2, vitamin C, and thyroid peroxidase. All those things help to make T4. The vast majority of the thyroid hormone that's made from the thyroid gland is T4. It is the inactive form. It needs to get a ride by something called the thyroid binding globulin so that it can be carried into the liver, the gut, and the peripheral tissues to make thyroid hormone. 60% goes to the gut, 60% goes to the liver to be converted to T3, 20% goes to the gut to be converted into T3, and 20% goes to the peripheral tissues to be converted into T3. To be converted from T4 to T3, we need the addition of some enzymes and a micronutrient called selenium. T3, once it's made, whether it's made directly from the gland or whether it's made via conversion in these tissues, then gets bound to a carrier protein called thyroid binding globulin, where it's escorted around the body. When it gets to a cell that needs some thyroid hormone, the thyroid binding globulin opens the doors, releases the thyroid hormone. T3 now becomes free T3, binds to the receptor site, gets into the cellular system with the help of vitamin D and vitamin A, it gets used by the cell. That is our thyroid physiology. So that's what we talked about last time. So this time we want to talk about primary hypothyroidism. So primary hypothyroid, in this condition, in this situation, what's happening is you have a TSH level that is elevated and a T4 level that is low. And so if your doctor's only running a TSH and a T4 level, they're going to find this pattern, all right? And this is the most common pattern that's treated. It is not the most common cause of hypothyroidism. If you have low TSH and if you have high TSH, that means your cells are not getting enough T4 or not getting enough thyroid hormone T3, free T3, to bind to the cellular system and get into the cells. And so there's signals going to brain to say, hey, we don't have enough thyroid hormone, and the brain is starting to try and kick the pituitary into gear to make more TSH, to make more thyroid hormone. In this situation, the big question that we would ask in functional medicine is, why isn't it making thyroid hormone? If it's true primary hypothyroidism, well, you could have a tyrosine deficiency. Well, how would you get a tyrosine deficiency? Maybe you don't eat protein, there are sufficient amounts of protein. Maybe you have low acid production, you have reflux, or low HCl production, a condition called hypochlorhydria. If you have that type of condition, you may not break down your proteins efficiently and then absorb the amino acids. And tyrosine is one of those amino acids that's needed to make thyroid hormone. So that could be a factor. You could have bacterial overgrowth or bacterial dysbiosis in the GI tract. Some bacteria use tyrosine as a fuel source. So they can use either phenylalanine, which is the precursor to tyrosine, or they can use tyrosine as a fuel source. If your gut bacteria is consuming the tyrosine, then that means you have less tyrosine to absorb and be used to make thyroid hormone. Not only would you have less tyrosine to make thyroid hormone? You would probably have less thyroid hormone to make dopamine, because tyrosine is a precursor for a neurotransmitter called dopamine. That's one of our feel-good neurotransmitters. So TSH high, T4 low. In traditional medical model, they're not really asking the question why it's not working. They're really just saying you're not making enough T4, thyroid gland's not working appropriately, we're going to put you on Synthroid or some other form of thyroid T4 hormone, maybe a bioidentical, and you're good to go. If that is the only problem in the whole thyroid pathway, everything else works appropriately, all our micronutrients are where they need to be, you're going to take that Synthroid, you're going to feel probably really good, your symptoms are all going to go away, your hair's not going to fall out anymore, your skin's not going to be dry, you have plenty of energy, you're going to lose weight, you're going to feel great. And you still may feel good and feel great when you first get it, but if there's micronutrient deficiencies and you're loading the system with more thyroid hormone, or there's conversion issues, you may get a little boost from that thyroid hormone, but in time, you're probably not going to feel too great. So, really important from our standpoint, not just to know that you have high TSH and T4, but what are the rest of the markers? What do the rest of those look like? What do the micronutrients look like? And we want to find out, or at least I do, why your T4 is low in the first place. Is it because you have poor diet? You have poor digestion, poor absorption of your micronutrients, low stomach acid production? Is it because you have bacteria that's stealing the tyrosine away from thyroid production? So we need to find out if it's tyrosine steal that's going on. We need to find out if it's just your dietary intake of protein is deficient. We need to find out if you have deficiencies of iodine or B2 or vitamin C, and is that thyroid peroxidase enzyme working appropriately? Okay? So primary hypothyroidism, you typically are going to see on lab work, TSH is elevated, T4 is low, probably the rest of the thyroid markers are going to be low as well. T3 will be low, free T3, free T4 will be low. T3 uptake, those values could all be normal, but the rest of the markers could be low. Your thyroid antibodies are probably going to be normal. They're not going to be positive. This is not a case of Hashimoto's. This is just primary hypothyroidism. This is what most people get treated for, is primary hypothyroidism, and that's what most people get put on some form of synthetic T4 or a bioidentical hormone. Okay? So that is primary hypothyroidism. It's probably less than 10% of the hypothyroid cases. It's probably what 90% of the patients get treated for, yet it's usually about 10% of the cases. So that's what primary hypothyroidism is, and this is where we're going to see the breakdown. TSH is elevated, T4 is low. In a traditional model, medical model, they're going to just give you thyroid hormone. In a functional medicine model, I want to know, why are you not making T4 to begin with? Is there micronutrient deficiencies? Is there gut infection? Is there inflammation that's stealing tyrosine? Or are you just not absorbing, not eating adequate protein, not digesting the protein appropriately, not absorbing the protein appropriately? So those are the differences between primary hypothyroidism and how we look at it from a medical standpoint and a functional medicine standpoint. So that's this Thursday's Thyroid Thursday video. Next time we'll talk about hypothyroidism secondary to pituitary hypofunction. Sounds complicated, but we'll talk our way through it and you'll have an understanding of it when we're finished. I'll see you next week.